I'm going to give a talk on collaboration. The examples that I'm going to give reflect the really great circumstances that you guys are now in. You gentlemen and ladies are embracing innovations, and you have an opportunity for collaboration. And that becomes hugely impactful on one of the points that Dr. Naidu was making earlier this morning, that for all of the stakeholders in healthcare, the value of what you do and the duration of benefit of what you do is becoming data-driven. And so participating in data gathering efforts is hugely impactful on the justification of the valuable work that you do. But it also can show how long this lasts and how you can be very cost effective compared to non-interventional and non-surgical treatments. So there's a natural alliance between spine care professionals around data that proves the merit of what you do. So let me get started with, this is probably the most important slide to remember, and the components of this are if you make incremental improvement in your practice, measure what you do, improve what you measure, you'll create wins for all of the stakeholders that are participating. If you promote your patient's interests, the interests of the payer, the interests of the policymaker, the interests of the product or device manufacturing company, or what I call the 5 Ps, the interest of pharma, you'll gather natural allies. If you own your data, you'll be in control of presenting the merit of what you do. If you stay on a data diet, that just means if it's really important, you want to measure it. If it's really attractive, you might not. And if you go around this room and we collected data, there are probably 3 important data elements, but there would probably be 7 data suggestions from each individual. And there's only 3 that really count. So stay on a diet. And then whatever you do, transparently report it, because it makes a world of difference. So what I'm going to do is first off go through 3 scenarios. One scenario is a surgical subspecialty that answers a question around quality and safety. And then the second scenario is going to be multiply related subspecialties revolving around collaboration for spine surgery. And then the third is diverse subspecialties collaborating in an effort that changes national authorization policy. And all 3 of these are data-driven. So let's look at general surgery. When you do a colon resection for cancer or for inflammatory bowel disease, and you plug it back together, you want to test to see that the anastomosis is solid and does not leak. And just like when you fixed a bike tire from a puncture, you would blow the tire tube up and stick it in a sink of water, and where the bubbles came up, that's where the leak is. So too, in general surgery, if you reanastomose a colon and fill the abdomen with water and charge the lower GI tract with a rectal tube under air pressure, if bubbles come up, you've got a leak. Trace the bubble track down to the leak, sew the leak closed, and the leak is gone. And so what we did in the state of Washington is we just asked the simple question, do you leak test? And initially, a minority of doctors leak tested. And all we did was publish the outcomes of surgery and the adverse events. Who went to the ICU? Who had to go back into the operating room for peritonitis? Who had mortality and morbidity? And which doctors leak test and which doctors didn't leak test? And what we found by transparently reporting the data is year after year, doctors noticed that leak testing was a smart thing to do. And now in the state of Washington, 100% of our general surgeons leak test. Nobody got forced to leak test, nobody got excluded from an insurance network, and nobody got sued. We just used a light to shine on the data, and that's a thing called the Hawthorne Effect. And what you can call the Hawthorne Effect is if you shine a light in an abandoned crack house, all the cockroaches run to the corners, and the center of the room is lit. If you shine a light on the merit of what you do and the benefits of what you do and the minimal adverse events of what you do, and you compare it across all of your colleagues in all of the subspecialties that participate in this work, so think of SI joint fusion, think of spine fusion, think of RFA, spinal cord stimulator. All of these have parallels that the Hawthorne effect will work in those circumstances. In this circumstance, what you see if you look at the author list, there are scientists, there are orthopedic surgeons, there are neurosurgeons, there is anesthesia, there's general surgery, there's orthopedics. And they all collaborated around a single topic of lumbar spine surgery. And what they were able to do, using this same Hawthorne effect, is develop predictive analytics around what works and what doesn't work. And it turns out the very important thing that is found is patient characteristics. And you will find the same thing if you do this work in spinal cord stimulation, or plug in any of the treatments that you do. But imagine you were going to plug in spinal cord stimulator instead of surgical parameters. You would find that there are patient characteristics and important outcome measures. This is a pain outcome measure. There's also a function, but I didn't put it on because it makes the slide too busy. But you can predict that in the circumstance of a 45-year-old female who's nicotine addicted and on narcotics in the L&I system, who really doesn't have much in the way of pain, if you operate on that patient, you have a 13% success rate. The converse is true. If you select based on, so imagine here you're putting in different characteristics for spinal cord stimulator, and here you're putting different patient characteristics, and down in this section you're putting in different process of care. What technology are you using? What levels are you at? Are you using a burst pattern? All of those things get listed. You'll be able to come up with predictions around who is going to benefit from the treatment. Now this is an example of orthopedic surgeons, scientists, interventional, pain clinicians all over the country participating in a registry around vertebral compression fractures, and the techniques for treating it were just concluded a short while ago. And what you found here is a massive number of patients. The N is around 700, and that's twice any other global registry. But what we were able to do is we were able to show this to Medicare, and it changed authorization for this procedure. And that's the point that Dr. Naidu was making earlier about gathering data around the things you do, because it helps you in conversations and in writing letters and lobbying for these evolving innovative technologies becoming a part of the standard of treatment. And the real world outcomes are very impressive. So some of the questions around, which time frame should you use for, how early or how late after the fracture can you treat? And you find with these procedures that there's immediate benefit. There's immediate change in the patient's ability to have a joyful life, and the pain is gone. And that's in all comers. You also are able to promote not only the patient's interest, where if you treat the patient promptly, they benefit immediately, and the benefit is sustained. But you can also tell the payer, if you make us wait 6 months, the condition is still terrible. They are profoundly painful, profoundly disabled, but you can still snatch victory from the jaws of defeat. The other thing it tells the payer is if you wait 6 months, your cost triples. And that's actually the number that the MACs, the Medicare Administrative Contractors, that's actually the number they paid attention to. It's the money. And that's what changed authorization. And when you bring data to the table, you can make those changes. Now, you all are embarking, as we saw in some of the techniques described here, in spine fusion surgery. And you have to understand that there are spine surgery societies, International and American Neurosurgery, American Orthopedic, Congress of Neurosurgery, Scoliosis Research, Cervical Spine, Lumbar Research Society. There are surgical societies that are against this. And that's always the case with innovation. The reason I'm speaking is collaboration is a much wiser path forward. Their concerns revolve around familiarity with anatomy and understanding of biomechanics. And as the other talk that was set to go this behind me, but my colleague got ill, managing adverse events and understanding the biology of the spine are important things. And if you come into this arena, you will want to collaborate around those important things, because your colleagues who live in this arena every day have a lot to contribute in understanding for you. So you want to reach out for that. And NAS has been really wise to try to formulate a balanced, inclusive approach so that anyone who's doing spine care has a similar fund of knowledge and has a collaborative relationship. And that's what I'd want you to think about, because this is what your spine surgeons think about. It's the biomechanics. There are entire texts on Dubosset's cone of economy. And you can see that cone of economy on this graph, where because of deformity in the lumbar spine, consequent to fusion, you see that's a flat back. And there's a compensatory hyperextension there. And in order for this patient's head to be level and look down the highway, they have to bend their hip, and they have to bend their knee. And they end up walking in a very energy expensive way. Because if they don't, they can't tilt their head up to see where they're going. So understanding what you are doing in this region of the body impacts this region, and it impacts the energy necessary to walk. So these things are critically important. And what you see in this is, since today's topic was SI joint fusion, which is right here, these are biomechanical parameters that have this long lever arm of impact. And so this is the skull. And understanding these biomechanical issues is really important. And that was really the point I wanted to make, is in collaborating, you want to expand your fund of knowledge in a manner that you participate with colleagues who can be helpful in these understandings. Because really what you want is collegial collaboration. That's really what you want. And the essentials of what that first slide that I said was so critically important, employing the Hawthorne Effect, because shining a light on what's good and what works and what doesn't work will allow you to change physician behaviors without it being punitive. And gathering real-world data will promote not only your practice, but it'll promote the interests of everyone else in the healthcare arena. And those 5 Ps of influence, the physician, the patient, the policymaker, the product and device manufacturer, the payer, all of those have to be taken into account. And your data impacts that. Any questions?
Awesome. So kind of moving forward, you've shown a couple areas of real victory, right? To this group, the change in LCD for Medicare, big time, right? And the registry was one of the primary drivers, if not the primary driver for that.
How many different devices did you see Doug display today? for cement augmentation? How many did Glenn display? That all came because doors opened.
Where do you see some of the next big areas that we could make strides? As you know, some of the collaboration, not only is it, we divide it kind of rudimentarily into surgeon versus non-surgeon, but so there's more conflicts than just that.
Yeah. So you have enormous opportunity in integrating innovative devices into surveillance mechanisms that generate massive data. You won't generate enough data for the patients of your individual practices, and you will not have enough time to write up those papers. But if you take multiples of yourself as individuals, 50, 100, society engagement around, and then everybody gets measured. So your spinal cord stimulator environment is ripe for this type of thing. And what you want to do is you want to also put what kind of physician is doing this, so that where you and your surgery colleagues overlap, like in the vertebral compression fracture registry, shows that overlap where multiple subspecialties are doing the same work, and you find that the outcomes are independent of the subspecialty, you've just proven your point. That you don't have to be a surgeon to do this well. You can be well trained, but you measure what you do, you improve what you measure, and you're transparent about how you're doing it. And you collaborate with authors so that the author list makes your point. That there are surgeon, non-surgeon, the broad variety, and there's no difference in the outcome data. And then you add the healthcare utilization cost of doing that to it, and you now have the value-based care equation. You've got the dollars, you've got the outcomes, you've got the duration of benefit. That's value-based medicine. And that's what your generation will need to do. So pick low-hanging fruit where you can collaborate with your colleagues, because that takes the naysayers off the podium. Because now they're looking at, well, geez, all of us do this really well. Maybe more of us can do more of this collaboratively and not antagonistically. It's not supposed to be adversarial. Is that it?
Yes.
Okay.
Questions, comments? Yes.
Neal, great job as always. This is one of the most important talks, I feel like, for the whole day, because this is our future. And as I mentioned before, I work with 2 spine surgeons, and you and Dr. Chapman, who unfortunately couldn't make it, and several other surgeons I speak to across the country are very supportive of a lot of these newer innovations and technologies. And as you said, we're gathering the evidence, we're gathering the data, making sure we're safe, making sure we're effective, and choosing the right patients. My question for you, though, is that I do also meet people who are completely adversarial, because I was not trained as a surgeon, because, all the reasons you mentioned. How do we talk to them? How do we influence them so that we can at least collaborate, get to that level of collaboration? And in the end, I may not be able to do what they want me to do, but at least we're talking.
Yes. So I've always believed that there's nothing new under the sun. And so look to other examples of collaboration. And the classic is cardiac interventional and cardiac surgery. And actually, if you can take it all the way back to Dean Ornish, who took the worst cardiac patients that the surgeons would not touch and did better with them than the best surgical case that the surgeons loved. And he did it with dietary change. So collaborate, and the best way to do it is to think of it initially comfort zones. You want to expand the comfort zones. So if there are surgeons who are uncomfortable with people coming into their territory, look at the cardiac surgeons who worked with their interventional colleagues, and the stent didn't go well, and an emergency call was made, and that patient gets routed right up to get open treatment. Work with your surgical colleagues so that you have somebody who has your back, and then show that relationship for the number of combined adverse events, or if you don't want to use CAE, use SAE, use serious adverse events, however you wish, transparently report it. And when you show, like we did in the vertebral compression fracture registry, I didn't stop on, but if you looked at the top of that slide, 754, 35, 700 plus, there's actually 1,094 patients in that we couldn't include some of it. But if you look at the top of that slide, there was a 0.5% adverse event. And those adverse events were not device related. So what does that prove? That surgeons of all stripes and interventional non-surgical colleagues did spine surgery very successfully with one of the largest outcome deltas in pain improvement and functional improvement ever recorded for a surgical procedure. And there were surgeons and non-surgeons on that paper. And that paper changed national administrative policy. So use prior examples, the cardiac surgeons, and use prior examples of success, mimic it. There's nothing new under the sun, so just apply it to a new relationship and make it work.
There's a couple of questions online here for you, Neal. One question here online is, what are some resources for registries for soon-to-be graduating fellows in interventional pain?
There's been an explosion of registry activity. Actually, some of it starting from the original spine registry work that was referenced in that predictive article and was preceded by a few articles beforehand. And so a lot of your societies have decided to do that. For ortho, there's the American Spine Registry, which is modeled after that one that I showed you, and the American Joint Registry, and shoulder and elbow are coming up. Your societies will sponsor it. That's sometimes helpful. An alternative way to look at it is there are folks who have exquisite experience, long track experience. TALO6 is a registry, TALOSIX is a registry company that builds registries nationally and internationally. And they're exquisitely good and have a long track record of doing it. The important thing in registries is to embrace heterogeneity. So that's heterogeneity of patient condition, all of the different conditions, that heterogeneity of physicians, all of the different kinds of doctors that do this work, and heterogeneity of process of care. Every widget way or technique you want to use, fine, be agnostic to all of it. And what you'll see is, as you transparently review the data, the cream rises to the top. And you'll find out if your physicians are equivalent. You'll find out if your processes of care are equivalent, or what really works and what doesn't work. And you'll do all of it without being punitive to anyone. You just measure what you do, improve what you measure. Measure what you do, improve what you measure.
Excellent. Any other questions from the audience?